You know what a survivor is, but in this episode, you're going to learn what a previvor is. I'm a previvor. 4 years ago, I reluctantly took a genetics test, and I say reluctant because I didn't want the certainty of knowing, and I was afraid of what I might find. And the results showed what I had feared, that I have a gene mutation that increases my risk of cancer, like my mom, who's been living with ovarian cancer for years now. And this genetic predisposition makes me a high-risk patient.
We have to acknowledge the anxiety that comes from the word cancer.
This is Michelle Zimmerman.
And I'm the CEO and co-founder of Previvor Edge, which is a cancer prevention and early detection clinic. And I think it takes time for people to be in a headspace where they can consume the potential for that information.
Michelle is a previvor too.
I've been steeped in this space for almost a decade, and I get anxious when I think about cancer. I got anxious when I took my own genetic test, even though I knew that information would be empowering, because cancer is scary. I had the kit sitting next to me, and you have to not eat or drink before you give the saliva sample, and I kept forgetting. There's another issue which we have is I have something I have to get done today. Let me put this off for tomorrow. It is like partially the fear, but it's also partially it's not acute. You don't feel it right in front of you right now, and so you're willing to put it off.
Michelle says most people learn that they have a genetic mutation after they're diagnosed with cancer. And that is something that can be prevented. Turning the fear of the unknown into an opportunity is important because
the average person has a 40% chance of being diagnosed with a cancer in their lifetime, so cancer is not rare.
This is Overlooked, and I'm Golda Arthur. In this episode, Michelle Zimmerman and I talk about what a previvor actually is, why knowing your genetic risk matters, and exactly what you should ask your doctor to understand yours. The newsletter that accompanies this episode has a deeper dive into this topic, and you can subscribe to it at the link in our show notes. That's all coming up after this break. Michelle, hi, and welcome to Overlooked. Thank you so much for doing this conversation with me.
Thanks for having me.
Obviously, we know what a survivor looks like and is from cancer, but this is going to be a new word for a lot of people. So bring that word to life for me. What is a previvor?
Previvor is a person who carries a genetic risk for developing cancer. It is particularly compelling because, well, today we know of 77 different genes that contribute to increasing cancer risk. There are some genes, like the BRCA1 or 2 gene, that are what we call highly penetrant, meaning they meaningfully increase your risk of developing cancer. So, for example, they could take a woman's breast cancer risk from 13%, which is the average lifetime risk for any woman to develop breast cancer, up to 87%. And so, that is what a previvor is someone who does not yet have cancer, but is at increased risk for developing cancer. For us at Previvor Edge, we use the word a little differently. We've sort of broadened the definition. Given how common cancer is, right, you almost have a 50% chance of being diagnosed with a cancer. Previvor is really, I have not yet been diagnosed with a cancer. It is also, and it's interesting, we have been seeing survivors, I have not yet been diagnosed with a second cancer. And it's sort of the space that exists when you are cancer-free before you have a cancer diagnosis, where we have opportunity to manage that risk.
What do you think is the most overlooked aspect of previvorship, if I just made up a word? And where is that inequality felt most deeply?
There's a lot, but I would say we're not even having the conversation. We don't talk about it, meaning an in-depth family history is not done. And I'm going to use previvor in the broad sense, not necessarily in the narrow sense, but the patient's in front of the clinician, and there's many, many, many different topics to cover in a primary care visit. And what you need in cancer is a very deep dive into that family history and what it means. And you need a deep dive into your clinical risk score for breast cancer. You need a deep dive into whether genetics matter. And you need a deep dive into your lifestyle. And you need to look back and say, did you get vaccinated for HPV and Hep B or not? You have to do that. And I think the first step is bringing awareness to this issue about managing cancer risk and having the conversation. I think a second issue is insurance reimbursed access to additional services you need in support of your elevated risk. Why is it that we say a mammogram is a preventive service? And so everyone is getting it as a preventive service. But if you have elevated risk and you need an MRI, it's now not a preventive service. Well, you actually needed that. And it is a preventive service for you. So different states have different access policies. But I think I would say that's a second piece. Like one is making this kind of clinical discussion standard of care. And the second is making it really easy to access the services that are warranted because of someone's risk level.
At Previvor Edge, how do you work with patients?
We are a clinical program, meaning you can access us the way you access any other doctor. The program is delivered virtually. We're a network with major commercial payers like Aetna, Cigna, United, and the Blues. So you can use your insurance. And you're basically scheduling a visit. You're going to meet with an expert, either a physician or an oncology nurse practitioner. And they're going to do a very deep investigation into your health, your lifestyle, and your genetics, and your blood work. And they're going to read your scans, and they're going to help you really understand your risk of developing cancer. Then they're going to put together a plan with you about what you can do to either screen differently or reduce your chances of getting cancer. And then they're going to work with you to implement it.
It's an interesting thing. I've not heard this term Previvor very much, but I remember the first time I heard this term, and I should disclose you and I are both technically Previvors, right?
That's true.
And the first time I heard it, I did feel like I had suddenly been drawn in or stepped into a world that I didn't identify with belonging in, right? And that is the world of cancer, because I didn't have cancer. But suddenly I'm like in this circle. And it was not a comfortable feeling, I can tell you that much. And my own story is that I resisted taking the steps that I knew would give me certain knowledge, or more certain knowledge than I had, just out of fear. What do you say to people who are a little resistant to knowing more about their risk of cancer?
You are not alone in your thinking is the first comment I'll make. I mean, I think the second comment is helping people to reframe that information as something that is both a reality and has an emotional aspect to it, and an opportunity to change an outcome.
Uh-huh.
And I'll just give you an example. We had a patient come to us at Previvor Edge who had a significant family history of cancer, really needed genetic testing, had put it off for years. And she finally went through it with us. And we said, well, why did you do that? She said, because I knew there was going to be a clinician on the other end working with me to help me through this and make the decisions.
I want to talk about that anxiety a little bit more and ask you a follow-up question on what you just said. When you took your first genetic test, even though you're sort of in this space, can you tell me about that? What was the test? How did you take it? How were you feeling?
It's interesting. I ended up just doing actually a test online in a nonprofit group that I was advising. And I got there because my primary care physician, at an elite academic medical center in New York, referred me to another academic medical center to see a genetic counselor. And I waited 6 months to get an appointment. And then another 6 months when they canceled on me. And I said, I'm just going to go get it myself. Even though I knew there was no chance I was going to have a very intense mutation, meaning something that gives you a really significant increase in risk, because both my parents had been tested. And I knew that the mutation that I could carry, which I do, confers a little bit of increased risk, but you would end up doing a bit more screening. So I even knew what the potential outcome would be. But when I took the test, all I could think about was cancer. It is just a scarier experience to think about cancer than it is to think about diabetes, because you hear the horror stories.
And tell me a little bit about your family. You mentioned that there was a great deal of cancer in your family, which led to all the genetic testing. So tell me a little bit about that.
Yeah. On my mother's side of the family, I have, at least three great uncles who passed away from gastric cancer very early. I have first and second degree relatives with cancers, different types of cancer. I have a cousin who survived stage 4 pancreatic cancer. His son had testicular cancer. There's just a lot of cancer. And frankly, the reason that we went down this genetics path was because when one of my family members was diagnosed, there was a research trial and they were testing everybody with his diagnosis. And that's when we found the mutation. And so, I have watched family members get diagnosed early because they were on an enhanced screening protocol. I have watched family members get diagnosed late because we were totally surprised by it. But it became very clear to me that we just don't have the conversation early enough. And nobody was equipped with information and knowledge about what could happen for them.
So, okay, let's talk about how to equip people, right, with the information and knowledge. How we detect cancer early has changed, and I think most people are not aware of specifically how much it's changed and what's available to us right now. So tell me what's changed about it.
The first thing is some cancers can be more easily detected than others. Some of that is based off of how quickly the cancer grows, giving us more opportunity to look for it every year versus something that grows very quickly. The second is whether we can actually test it from a biological perspective. How easy is it for us to go and run that test? How does the tumor shed in the blood? Can we actually get to the tissue? So there's some practical considerations. And then the third piece is how well is this integrated into the standard of care where we can take the findings and take action off of it? Cervical cancer screening is quite interesting because it's actually not a very good test, meaning you miss cancers and you say there is a cancer when there isn't a cancer. Even though the pap smear was really not a good test, because it was adopted broadly, because cervical cancer was so common, because it was done frequently in a serial kind of way, and because we had well-established clinical pathways about what to do next, we did a great job at reducing the rate of cervical cancer, even though it wasn't a great test. And cervical cancer grows very slowly. So you have the opportunity to find something early enough that it doesn't even become a cancer. And you can contrast that to ovarian cancer. Ovarian cancer is far more rare, it grows quickly, and we don't have very good detection tools. There was a study that was done that combined transvaginal ultrasound with a blood test called a CA-125. And even though it caught more cancers, it did not affect mortality because the cancers were caught late, because it grows quickly. And so when we think about detection, it's important to understand how the cancers grow. So colorectal cancer can grow slowly on average, which is why we can do colonoscopies and we can do fecal tests and we can catch precancerous polyps and we can remove them. Breast cancer is also, except for triple negative breast cancer. So these have been more effective and we do them every year. We do them serially. But leukemias can grow very quick and pancreatic cancer can be very quick. And so we have to just think about the prevalence of a cancer, the rate of growth of the cancer, and the ease at which we can go look for a signal. And I think, something that is obviously very exciting is what we're seeing in what I call blood-based screening. Liquid biopsy, probably the most well-known is Grail's Gallery test, a multi-cancer detection test. But what we need to understand is this one blood test is looking for every kind of cancer. And as I said before, every cancer is different. And so the performance is going to vary.
So let me ask you about, was there a moment in your life where you thought to yourself, I have to know what my genetic risk is?
There's multiple times in life where you're going to get genetics. And I would say, I want to know the genetics I can do something about today. If there's nothing I can do about it right now, I don't really want to know it. Because what's the point? If I can do something about something in 10 years, then I'll go do the genetic test because then it's immediately actionable. If I can't do something about it, it's more anxiety increasing because there's nothing I can do about it yet. And so I think the first time you deal with genetics is if you're going to have children and you do carrier testing, which is designed primarily to tell you about your future offspring, but can also tell you something about yourself. I carry something called factor 11 deficiency, which is a blood clotting disorder. It's genetic. And you learn about it on carrier screening. And it's actionable. It actually totally affects how you deliver your child. So it's very relevant. The cancer testing is very relevant because it's going to affect how I screen today. If you ask me, do I want to know if I'm going to get Alzheimer's right now? Because what am I going to do about it? But in some time from now, where there's actually something that I can do early if I have that, I'm very interested in getting that information. And so I think for me, it's how is the information going to affect what I do today? And how does that give me the best opportunity to get the best outcome? And it's less about pure curiosity. It's more about practical, I hate to use the word like longevity. And so I think like on the cancer side, it was very clear to me when people in my family carried mutations and I was running a business, I should probably get it done.
I think that is a really important thing, what you said about Alzheimer's, right? Because I think this is what stops people. It's not just that, okay, I can get a test and I can get more information. It's that how does that information turn actually into empowerment? And I think there's a little bit of a gap there too, right? Between what's knowable and what's actionable. So let's talk about how this gap gets filled and our role as patients in being part of that movement, in advocating for ourselves, and take it down to like just the individual level. What should patients like us, just regular folks, what should we be doing? What should we be saying at our primary care appointment? How should we be advocating in order to fill this, what seems like a huge gap, Michelle?
Okay, so if you're going into your primary care physician, you could say something like, I'd really like to talk about my cancer risk. Could you help me understand what are the things that might change my cancer risk and what I can do about it? All clinicians are going to come with different knowledge bases and comfort level. But you as a patient should know my family history matters. And so if you have a family history, you bring that up. If you're a woman, you ask your clinician to calculate a breast clinical risk score, Tyrer-Cuzick risk score. If you have a family history or you're even Ashkenazi Jewish, you ask for genetic testing. You ask them about the lifestyle. You say, what are the things that I could be doing in my lifestyle that will reduce the chances I get cancer? Can you tell me about those? Now, those are also pretty well established on the American Cancer Society, so you can also self-educate yourself. There's not that many. It's exercise, it's alcohol, it's smoking, it's processed foods, it's red meat, it's sunscreen, it's fruits and vegetables. There's not that many. And it's all the same stuff you're going to do to manage cardiovascular risk and metabolic risk. You should get on that. If you are overweight, if you have a high body fat percentage, you might want to talk to your doctor about things you can do to manage that, because that is a big risk factor for cancer. And so I think like those are the big things. And there are very specific things that your doctor can do to help you. They can help you.
That's super useful, actually, to know, because I think sometimes people just don't understand these steps or don't understand the language that they should use that starts off these conversations and that kind of thing. So let's talk about access for a second. We're talking about how the needle has moved in early cancer detection and how the science is evolving. And whenever I speak to people who are like, here's this really hopeful tool that's coming down the road, right? Like the tools we're about to get in cancer, the knowledge we are starting to receive in cancer is wild. It's great. It's cause for optimism. But my thing is like, we're not moving until we're all moving, and we're not all moving. There's a huge segment of the population in every country in the world that is being left behind of all this hopeful, optimistic stuff in terms of moving the needle on health. What are your thoughts on that, on making this new technology more accessible, more available to everybody, as opposed to just those who can pay for it or those who have the luxury of putting their health above all else?
Implementing new technologies into standard of care is very difficult. I know we're talking about previvors or cancer prevention detection, but I just want to give you an example on affected cancer patients because I spent a lot of time there in a past life. We have something called tumor profiling, which is sequencing tumors to identify what mutations exist so that we can optimize what kind of treatment we give to somebody. We have shifted over decades from everyone gets the same chemotherapy to targeted therapy to immune therapy, and profiling an individual and their tumor is critical. I'll give you one other example, which is, do you test for 5 genes? Do you test for 250 genes? Do you test for 18,000 things? If you are the cancer patient and you're sitting there, you're saying, oh my God, go test for 18,000 things so we know what we're going to do. And if you're the insurance company, you're like, no, we're going to pay for 4 things. But if you're the mother of the person who works at the insurance company, I would be surprised if they're not testing for 18,000 things. And the evidence that those 18,000 things are actually going to find something actionable that will be missed is there. And you just have this gap. And the gap is clinicians need to be trained on these new technologies and they need to be comfortable implementing them. The gap is the insurance company needs to make it easy to access these technologies and implement them. And then in the absence of that, the patients who are savvy are going to go online and they're going to find companies who will do this for them and they will pay out of pocket. Or they're going to go to an elite academic medical center who's going to do this as a combination of research and clinical care, and they're going to get it there. It is no different really on the prevention side, which is 90% of people learn that they have a genetic mutation after they're diagnosed with cancer, like a hereditary cancer mutation. 25% of people who got colorectal cancer in their 40s had a family history and should have been screened earlier. And so you have the same problem here because how do you integrate these new guidelines into the workflow? How do you get coverage for the things that the patient needs? It takes a very long time for new things to become standard of care, and there's competing priorities. And so the best thing that we can do is create a movement and say, what does good look like? We created a movement around cardiovascular disease. We said everybody should get metabolic screening, right? Insurance companies pay members to go get a blood test to find out if they have metabolic syndrome so they can help you not get diabetes and cardiovascular disease, and that is standard of care. Well, why aren't we doing the same workup on people for cancer risk? When we want to change something, there's a cultural shift.
Thank you so much for having this conversation with me on Overlooked. I learned a ton, and I hope everybody else did too.
Thank you. Thanks for having me.
Overlooked is here for information and empowerment, but not medical advice. Every person's body is unique. So if you have questions, it is best to speak to your doctor or healthcare provider. We're building a community around women's health so that no one is overlooked. If you'd like to be part of it, hit the follow button on this podcast, wherever you're listening to this. Or you can show us some love by writing us a review and sharing this episode with someone. Overlooked is written and created by me, Golda Arthur. Jessica Martinez de Hoz is the show's producer. You can stay up to date with the show by signing up for the newsletter and following us on Instagram and LinkedIn. We read every review and email, so write to us, hello@overlookedpod.com. Thanks for listening.